Welcome to the Deep Dive. Today we're tackling a subject that many of you have actually asked about. It's the often confusing world of statins and cardiovascular health.
Yeah, it's definitely a hot topic.
For years, we've basically been told, high LDL cholesterol is bad, a major threat, and statins. They're the main weapon against it.
That's certainly the established view, absolutely.
Wow.
For many people, it feels like settled science, but we're going to explore some different perspectives today.
Perspectives that suggest the whole relationship, cholesterol, statins, heart disease, well, it might not be quite as straightforward as we've been led to believe.
Exactly. There's quite a bit of nuance that often gets lost.
And guiding us through this is Dr. Aseem Malhotra. He's a UK cardiologist, and he's become a really significant voice, challenging some of that conventional wisdom around heart health.
Well, my background is certainly part of why I've reached these conclusions. I mean, having practiced cardiology within the NHS, I saw the dominant narrative around cholesterol and statins firsthand.
Right.
So my current position, it really comes from let's say, a careful reevaluation of the evidence over time.
And his experience, being inside the system, it gives him this unique viewpoint. Some of what we'll discuss might honestly be quite jarring, make you reconsider things.
It might challenge some long-held beliefs, yes.
And this isn't just like a theoretical debate either.
Yeah.
Quite recently, two of Dr. Malhotra's colleagues, Dr. Zoe Harcum and Dr. Malcolm Kendrick, they won a pretty significant defamation lawsuit.
Ah, yes, against the Mail on Sunday newspaper.
Exactly. The paper had called them statin deniers, accused them of spreading deadly propaganda. And this was part of a campaign before COVID about fighting fake health news.
Right, that timing is interesting. And while I wasn't, personally involved in that specific legal case, I absolutely supported Zoe and Malcolm.
Oh, of course.
Their win really underscores just how intense this debate can get and the seriousness of the accusations thrown around when you question the standard approach.
Okay, but here's where it gets, well, really interesting for Dr. Malhotra personally. Shortly after those articles came out, he actually lost his NHS job.
Yes, that's correct.
The hospital apparently cited concerns about his views on statins. They even used this phrase like antibodies developed against you.
Antibodies. That's quite a phrase.
Isn't it? And this happened despite him having a 23-year clinical record with, apparently, no patient complaints or issues whatsoever.
That situation, well, it really highlighted the pressure within the medical system, the pressure to just stick to the established guidelines.
Assume so.
It suggests that, even experienced doctors with good track records can face real consequences for voicing evidence-based concerns if they go against the grain.
And those concerns are the core issue for Dr. Malhotra and his colleagues. They really revolve around what they see as, well, flawed data, maybe an overemphasis on statins, definitely overprescription.
And the potential risks, the side effects that maybe aren't discussed enough?
Right, and also missing other crucial factors in heart health. It's important you understand this isn't just a simple drugs are bad argument. It's much more nuanced.
Precisely. The argument is more that focusing almost exclusively on lowering LDL cholesterol with statins might be, well, too narrow. We might be missing bigger drivers of heart disease.
Now, that Mail on Sunday article that kicked off a lot of this, it actually linked the whole controversy to the Secretary of State for Health at the time, Matt Hancock.
Yes, it suggested he'd said something like there was no place in the NHS for doctors spreading, quote, misinformation on statins.
But what came out in court was pretty revealing, wasn't it?
It was quite extraordinary, actually. Just a week before that article was published, I'd personally met with Matt Hancock.
You met with him? About what?
We discussed my work on lifestyle interventions, specifically around reversing type 2 diabetes, so he was aware of my work in that area, the lifestyle approach.
Okay, so let's unpack that. Hancock meets with you, knows about your work. Then a week later, there's this article quoting him about misinformation on statins.
And then, in court, he stated he had no idea. His comments referred to me or my colleagues, Zoe and Malcolm.
Wow. And that piece of evidence reportedly really swayed the judge in favor of your colleagues.
It certainly seemed to be a pivotal moment in the case, yes. It definitely raises questions about the motivations behind the newspaper's very strong stance.
Yeah, for the health secretary who just met with someone seemingly targeted by this, to then claim ignorance. Well, it's quite something.
It is.
And the Mail on Sunday's health editor, they didn't hold back. There was an editorial headline suggesting a Special place in hell for doctors saying statins don't work.
Yes, that language really ramps things up beyond a scientific discussion into something, well, much more personal and aggressive.
It's hard not to see that as a direct shot at you and your colleagues.
It felt that way, yes.
So who might have been fueling this really strong reaction? Reports suggest the Cholesterol Trialist Collaboration, the CTT, based at Oxford, played a role.
Ah, the CTT. They're major proponents of statins, yes.
And they receive huge amounts of funding. We're talking hundreds of millions from the very companies that make statins.
And that's a critical point to consider, isn't it? The potential for financial ties to influence research and recommendations. It's a known issue in medicine.
So when a group that's heavily funded by drug makers is actively promoting the drug and, seemingly influencing media coverage,
You have to acknowledge the potential for conflict of interest. It's just essential. Even if it's not explicitly declared everywhere, that possibility exists.
it reminds me of something you mentioned about Peter Libby, a former editor of a big cardiology textbook.
Ah, yes. He reportedly said something along the lines that he knew lifestyle changes worked for heart disease, but it was just so much easier to get funding to study drugs.
Whereas funding for lifestyle research was, what, scarce?
Very difficult to come by, comparatively. That anecdote really shines a light on the skewed landscape of medical research funding. Pharmacological treatments often get way more attention than lifestyle approaches.
And adding to that concern about published research, there's the work of Professor John Ioannidis at Stanford.
Yes, his paper, Why Most Published Research Findings Are False, a landmark piece.
He points out how financial biases, among other things, can just lead to unreliable results in a field.
And when you think about statins, it's a trillion-dollar global industry, the #1 best-selling class of drugs worldwide. The financial incentives are just immense.
They really are.
Exactly. The sheer economic weight of the statin market creates this incredibly powerful incentive to maintain the status quo, the prevailing view.
Doesn't automatically mean all the research is bad, of course, but
But it absolutely underscores the need for rigorous, truly independent evaluation, which is often lacking.
and that independent evaluation, you argue, is often hampered. Lack of proper informed consent for patients, maybe?
That's one major issue. And also restricted access to the actual raw data from the drug company trials.
So we don't get to see everything.
Often, no. And then there's the huge problem of unpublished trial studies that showed negative results or no benefit that just never see the light of day.
So we might only be seeing a curated slice of the evidence.
That's the concern. If studies suggesting harm or lack of benefit are simply withheld, it creates a distorted picture of a drug's real effects, both good and bad.
It makes you think of that old Mark Twain quote, doesn't it? Lies, damned lies and statistics.
It's a very apt comparison, unfortunately. Without full transparency, access to all the data, raw data included, it's incredibly difficult to make a truly objective assessment of any treatment, statins included.
And the scale of use is just staggering. Estimates suggest anywhere from 200 million up to maybe even 1 billion people worldwide are prescribed statins.
It's a massive global health intervention. Given that scale, it's absolutely critical, ethically vital, that the evidence supporting this widespread use is truly robust.
And that doctors and patients have a crystal clear understanding of the actual benefits and the potential downsides, not just relative numbers.
Absolutely. The absolute benefits.
Your own journey with statins is quite revealing too. You started out as a believer, right? Prescribing them frequently.
Oh, absolutely. Early in my career, I prescribed them regularly, even in the emergency setting for heart attacks, as per the guidelines. I believed in the narrative.
So what changed?
Well, my focus shifted over time towards looking at the root causes of chronic disease, particularly heart disease, and the potential for actual reversal, not just management. That led me to question many established practices, including the widespread use of statins.
It reflects a broader shift maybe in some parts of medicine towards prevention and root causes.
I think so. There's a growing movement looking for a more holistic and preventative approach.
You also stress that medicine isn't perfect, it's always evolving. Evidence-based medicine. It's supposed to be a triad, right?
That's right. It should integrate 3 things: the best available research evidence, the clinician's experience and judgment, and crucially, the patient's values and preferences.
But often it gets skewed.
Very often, yes. It gets misinterpreted to mean only the published research matters. And as we've discussed, that published research can itself be biased by commercial interests.
So the clinical experience and patient choice get sidelined.
They can do, yes. which isn't true evidence-based medicine at all.
And didn't Richard Horton, the editor of The Lancet, make a pretty shocking statement about published research?
He did. He famously stated that possibly half the published literature is simply untrue, coming from the editor of one of the world's top medical journals. That's a stark assessment.
It really is. It underlines the systemic issues and why we need that critical thinking, even with big studies.
Absolutely. A healthy skepticism is necessary.
You argue that medical knowledge itself is in many ways shaped by these commercial forces,
Yeah.
and many doctors are just unaware.
I think many doctors operate within this system without fully realizing the extent of the influence. They prescribe based on guidelines, journal articles, often unaware of the underlying financial dynamics shaping that information.
Which is tough, because most doctors are genuinely trying to help their patients.
Of course they are. The vast majority are dedicated professionals. But if the information they rely on is skewed, even subtly, by commercial imperatives, it can inadvertently lead to less than optimal care.
And despite decades of widespread statin use, we haven't wiped out heart disease, have we? I mean, Nobel laureates once thought we might by the early 2000s.
No, sadly not. Heart disease remains the #1 killer globally.
But fewer people are dying from heart attacks, aren't they?
Yes, mortality from an acute event has decreased, but that's likely due to major improvements in acute care. Things like smoking reduction, much better emergency treatments, paramedics, stents, defibrillators.
Not necessarily the statins preventing the disease itself on a massive scale.
That's the argument. Improved survival after an event doesn't automatically mean the underlying disease process is being effectively prevented by widespread statin use in the population.
In fact, wasn't there a BMJ study looking at Europe?
Yes, a significant study published in the BMJ. It found basically no reduction in cardiovascular mortality across Europe over a decade, even though millions more people started taking statins during that time.
That seems counterintuitive if statins were having a huge impact on death rates.
It certainly prompts a reevaluation, doesn't it? A reevaluation of the magnitude of the real-world impact of broad statin use on overall death rates from heart disease.
And when we look at those industry-sponsored trials, you remind us they often show a best-case scenario, right? Carefully selected data.
They often do. The highly controlled environment of a clinical trial, often with very specific patient selection criteria, might not accurately reflect how these drugs perform in the messy reality of a diverse population with multiple health issues.
Right, people with comorbidities, older people.
Exactly. Real-world practice can be quite different, and side effects might be more common or varied.
Okay, let's talk numbers. The average increase in lifespan, life expectancy, from taking statins, if you've already had a heart attack, secondary prevention, what is it?
Across the major trials, when you calculate the median increase in life expectancy over about 5 years of treatment, it comes out to just over 4 days.
4 days, over 5 years.
Yes, 4 days. It's a surprisingly small figure when you state it like that, especially for such a widely used drug class.
That really puts the benefit into perspective. When we look at absolute benefit, it seems much less impressive than the relative risk figures we often hear.
Precisely. Relative risk reductions can sound large, but the absolute benefit in terms of actual life extension is often very modest.
Which brings us to this concept you champion, numbers needed to treat, or NNT. Can you explain that?
Sure. NNT tells you how many people need to take a specific treatment for a certain period, usually 5 years in these trials, for just one person to experience a specific benefit, like avoiding a heart attack or having their life prolonged.
Okay, so for secondary prevention after a heart attack, what's the NNT for saving or prolonging one life over 5 years?
It's around 83. You need to treat 83 people who've already had a heart attack with a statin for 5 years for one person to live longer because of the statin.
So 82 out of those 83 get no survival benefit in that time frame.
Correct. They might get other benefits, perhaps preventing a non-fatal event, but in terms of living longer, the benefit accrues to only 1 in 83 over 5 years.
Wow. Okay, what about primary prevention, people who have never had a heart attack or stroke?
Well, for primary prevention, the data is even less compelling regarding lifespan. There's generally no demonstrable benefit in terms of prolonging life.
No extra lifespan.
Not shown consistently in the major trials for primary prevention. The best case scenario suggests maybe a 1% absolute reduction in the risk of having a non-fatal heart attack or stroke over 5 years.
1% absolute reduction in the NNT for that.
It's around 100, maybe slightly more, depending on baseline risk. So you'd treat 100 people for 5 years to potentially prevent one non-fatal heart attack or stroke in one person.
With no guarantee they'll live any longer overall.
Correct. And the other 99 people receive the drug, experience any potential side effects without getting that specific benefit in that time frame.
This is where that difference between absolute and relative risk reduction, which Gerd Gigerenzer talks about, becomes so critical.
Absolutely crucial. A drug company might trumpet, say, 30% relative risk reduction. That sounds huge.
It does.
But if your absolute risk of having an event over 5 years is already very low, let's say only 1 in 100, which is 1%, then a 30% relative reduction only brings that risk down to about 0.7 in 100.
So the absolute benefit is only 0.3%.
Exactly. Tiny for the individual, even though 30% sounds impressive. This is why understanding absolute risk in NNT is ethically imperative for informed consent.
You've really pushed for this, haven't you? For more transparency using NNT, you even co-authored a BMJ paper on it.
Yes, with several presidents of UK Royal Medical Colleges, we argued for using absolute benefits in NNT in patient discussions. It gained some initial traction, which was encouraging.
But it seems to have faded a bit.
Unfortunately, yes. It's often an uphill battle to keep the focus on these crucial nuances, especially when facing powerful commercial interests and deeply ingrained medical beliefs. Maintaining momentum is hard.
You also mentioned something called opposition fragmentation, a tactic used by industry.
Yes, it's a term used to describe tactics employed by industries to undermine critics or those challenging their interests. It can involve funding supposedly independent groups or think tanks to attack dissenters. Sow doubt, create confusion.
You cited the American Council on Science and Health as one example.
Yes, groups like that have often been involved in defending industry positions and attacking critics, sometimes without full disclosure of their funding. It's a recognized strategy.
It reminds me of what Simon Chapman, the tobacco control expert, observed.
Ah, yes. His point was that if you seriously threaten the interests of powerful industries or deeply held ideological beliefs, you should fully expect to be attacked. It comes with the territory.
And you experienced that directly. Formal complaints made against you.
Yes, complaints were made to the Academy of Medical Royal Colleges, which ultimately led to my removal from some public health campaigns I was involved with.
Despite your arguments being based on your interpretation of the evidence.
Correct. It demonstrates the potential professional risks involved when you publicly express views that challenge the mainstream, even if those views are rooted in a careful analysis of the available science.
You quoted Gandhi in that context, didn't you? First they ignore you.
Then they laugh at you, then they fight you, then you win. Yes. It resonates because it often feels like the stages you go through when challenging an established, powerful status quo.
So let's trace that transition for you personally. How did you go from being a believer and prescriber of statins to where you are now? It wasn't overnight, clearly.
No, definitely not. It evolved over several years. My initial focus, going back maybe 10 years or more, was actually on the obesity epidemic. I started to realize how flawed the traditional low-fat dietary advice was, how it had inadvertently led to a massive increase in sugar and refined carbohydrate consumption. This became a central theme in my first book, The Piapi Diet, and later, Eat Fat, Get Thin.
Right, challenging the low-fat hypothesis.
Exactly. Then came my 2013 BMJ article, Saturated Fat is Not the Major Issue. That was a real turning point in my thinking.
How so?
Well, the logic followed. If saturated fat isn't the main driver of heart disease, as the evidence seemed to suggest, and we know saturated fat tends to raise LDL cholesterol, well, then maybe LDL cholesterol itself isn't the primary villain we've made it out to be.
That's a big leap from the standard narrative.
It was.
Yeah.
It directly challenged that long-held dietary dogma linking saturated fat, LDL, and heart disease. It opened the door to thinking maybe this is an oversimplification. Maybe LDL isn't the be-all and end-all.
You also started looking into how statins might work, beyond just lowering cholesterol.
Yes, I began to understand their other properties. They have anti-inflammatory effects and some anti-clotting or anti-thrombotic effects, too. These are independent of LDL lowering.
So any benefit they do have might not even be primarily because they lower LDL.
That's a distinct possibility, yes. The benefits could stem from these other so-called pleiotropic effects, which again questions the intense focus purely on the LDL number.
You also noticed conflicting views even within cardiology.
Absolutely. You had the old guard, it's the cholesterol stupid mentality from a famous 2011 article. But alongside that, a growing recognition of other crucial risk factors, inflammation, insulin resistance, clotting factors.
So the field itself wasn't entirely unified.
Not at all. This internal debate highlighted that the cholesterol hypothesis wasn't and isn't a universally accepted monolithic truth, even among cardiology experts.
And then you looked again at the original Framingham study data.
Yes, re-examining that foundational study. It suggested LDL was only a really strong predictor of heart disease when levels were exceptionally high, maybe around 250 milli-GDL or 6.5 millimol.
And below that.
Its predictive power seemed to diminish significantly, especially once you accounted for other factors like triglycerides and particularly HDL cholesterol. The ratio of triglycerides to HDL seemed a much stronger predictor.
So reanalyzing a cornerstone study cast doubt on LDL being the main independent risk factor for most people.
For me, yes, it suggested the focus on moderate LDL elevations might be misplaced.
Then you did a systematic review of cholesterol-lowering drug trials.
Yes, with colleagues. We looked across numerous trials of different drugs that lower LDL. We found no clear, consistent relationship between how much the LDL was lowered and the degree of cardiovascular event prevention,
Even in high-risk patients.
even in high-risk groups. You'd expect a clear dose response more lowering equals more benefit if LDL was the primary mechanism. But that consistent relationship wasn't apparent across all the different types of trials.
That's a pretty significant finding, challenging the whole lower is better mantra.
It certainly raised serious questions for us about the fundamental premise of aggressively lowering LDL cholesterol in almost everyone as the primary goal.
Which leaves the obvious question, why does that lower is better belief persist so strongly if this counter-evidence exists?
Well, as we've touched upon, it's likely a combination of factors. Huge commercial interests vested in maintaining the status quo, certainly.
The trillion-dollar market.
Exactly. Then there's deeply entrenched medical dogma beliefs passed down through generations of training, and perhaps a lack of widespread critical appraisal of the original data. Inertia plays a role, too.
And you also highlight potential downsides to statins beyond just muscle aches.
Yes, absolutely. There's a known increased risk of developing insulin resistance and type 2 diabetes. The estimates vary, but it could affect maybe 1 in 100 people taking the drug, possibly more in some analyses.
Increasing the risk of diabetes, which is itself a major risk factor for heart disease.
Precisely. That raises real concerns about the overall net benefit, especially for people starting at a lower risk of heart disease, but maybe predisposed to metabolic issues.
Is the benefit worth that potential harm?
That's the crucial question that needs individual assessment.
And you mentioned the illusion of protection.
Yes, the idea that someone taking a statin might feel sort of medically protected and therefore less motivated to make or maintain healthy lifestyle choices, like eating well or exercising.
So the pill might inadvertently lead to worse lifestyle habits.
It's a potential psychological effect, unfortunately. Any small benefit from the drug could be completely negated or even outweighed by worsening lifestyle factors.
And this laser focus on LDL, has it maybe overshadowed other really important metabolic risk factors?
I strongly believe it has. The obsession with LDL has, to some degree, diverted attention, research funding, and clinical focus away from tackling arguably more important drivers like insulin resistance.
Which is linked to diet and lifestyle.
Predominantly, yes. Poor diet, lack of activity, chronic stress. And you also suggest insulin resistance might be underdiagnosed. I think it often is. Perhaps partly because, historically, there haven't been as many highly profitable blockbuster drugs specifically targeting insulin resistance compared to cholesterol.
So commercial factors might even influence diagnostic priorities.
It's a potential factor, yes. If there's no big drug solution, a condition might receive less attention in guidelines and practice.
So you advocate for a much broader, more holistic view of risk, looking beyond just LDL.
Absolutely. We need to look at the whole picture. Insulin levels, certainly. Lipoprotein A, or LPA, that's important.
Can you explain LPA briefly?
Sure. It's another type of cholesterol-carrying particle. High levels are largely genetically determined, and it's recognized as an independent risk factor for heart disease. Crucially, statins don't lower LPA.
Okay, so LPA. What else?
Things like APOB, which reflects the total number of potentially atherogenic particles. Particle number and size can be more revealing than just the total cholesterol content, and of course, markers of inflammation.
Right, so a much more comprehensive metabolic and inflammatory assessment.
Yes, that gives a far more accurate and nuanced picture of an individual's true cardiovascular risk than just looking at LDL in isolation.
And studies have shown, haven't they, that many people having heart attacks actually have diabetes or prediabetes.
Yes, a surprisingly high prevalence. Some studies show over 2/3 of heart attack patients have underlying diabetes or prediabetes, often undiagnosed before the event. It really underscores the critical role of blood sugar regulation.
It points again to metabolic dysfunction being a key driver.
A very significant underlying driver, yes.
Now, you do acknowledge conditions like familial hyperlipidemia, FH, the genetic one, with very high LDL.
Yeah.
Treatment might be needed there.
Yes, FH is a specific genetic condition where LDL levels are extremely high from birth. Intervention might be more clearly indicated for some with FH. However,
There's a but.
even in FH, lifestyle still plays a crucial role. Many people with FH also have underlying insulin resistance, often driven by modern diets. Addressing that through lifestyle diet, exercise, stress management can dramatically reduce their risk, independent of the LDL level.
So even with genetic high cholesterol, lifestyle is key. And checking LPA is important too.
Absolutely critical in FH patients as well.
Okay. And as a counterpoint to the whole lower LDL is always better idea, you mentioned a 2016 review of older adults.
Yes, a systematic review looking at observational data in people over 60. It found no significant link between LDL cholesterol levels and heart disease in that age group.
No link.
No clear association. And intriguingly, it even suggested an inverse relationship with all-cause mortality.
Meaning higher LDL was linked to living longer overall.
That's what the observational data suggested in that over 60 population. Higher LDL was associated with lower overall mortality.
Now, observational data isn't proof of cause and effect, but
Exactly. Correlation isn't causation. We must be cautious. But these findings certainly raise fascinating questions about the assumption that lower LDL is universally beneficial, especially as we age.
are there biological reasons why higher LDL might be protective later in life?
Well, possibly. Cholesterol is vital for many functions: brain health, hormone production, cell membrane integrity, immune system function.
So maybe lowering it too much could be detrimental.
It's plausible. Some observational studies have linked very low cholesterol levels to an increased risk of things like infections and potentially even some cancers, though that link is more controversial and complex.
It just adds more nuance to the simple lower is better story.
It really does. It underscores that cholesterol has vital roles, and simply driving it down might have unintended consequences, particularly in older people.
And the role of inflammation keeps coming up. That's now widely accepted as key in heart disease, right?
Increasingly so, yes. Paul Ridker's work, including the Jupiter trial, really highlighted this. Heart disease is, in large part, a chronic inflammatory condition.
Often made worse by those metabolic issues we talked about, insulin resistance, blood sugar problems.
Exactly. Those metabolic factors are often potent drivers of chronic inflammation throughout the body, including in the arteries.
You co-authored quite a provocative editorial on this in 2017.
Yes, in the British Journal of Sports Medicine, along with the editors of JAMA Internal Medicine and BMJ Open, the title was quite direct: Saturated fat does not clog the arteries.
That's bold.
Coronary heart disease is a chronic inflammatory condition, the risk of which can be effectively reduced by healthy lifestyle interventions. It was a direct challenge to the old dietary dogma.
And the fact that editors from other major journals signed on, that's significant.
We felt it was. It showed growing skepticism within parts of the medical community about the traditional dietary guidelines and the singular focus on saturated fat causing heart disease via LDL.
So, if it's not primarily LDL, and inflammation driven by metabolic issues is key, why does the LDL statin dogma persist so strongly? You come back to commercial influence.
I believe that's the primary root cause. Commercial distortions of the scientific evidence, corporate funding influencing medical education, physician training guidelines, even media reporting, what I often call the power of big pharma.
You've used the phrase tyranny of corporate influence.
Yes, where healthcare professionals might feel hesitant, even afraid, to voice dissenting views that challenge profitable products. Medical knowledge itself can become subtly shaped by commercial imperatives, often without practitioners fully realizing it.
It creates a difficult environment for unbiased science.
Very difficult. It can hinder open debate and slow the adoption of potentially better, less harmful approaches if they don't align with commercial interests.
There's psychological barriers too, right? Doctors changing long-held beliefs.
Absolutely. It requires humility, intellectual curiosity. It's hard to admit that what you've been taught and practiced for years might be flawed or incomplete. A highly commercialized system might not always foster that kind of critical reflection.
You even link the paradox of the U.S. highest healthcare spending, yet poor health outcomes partly to this corporate capture.
I think it's a major contributing factor, yes. When the financial incentives in healthcare are misaligned with genuine patient health, You can get that disconnect, high spending, poor results.
You talk about the commercial determinants of health.
Right.
What do you mean by that?
It's the idea that private sector activities, particularly large corporations, actively shape the environment in ways that promote unhealthy products and choices. Processed foods, sugary drinks, perhaps even over-reliance on certain medications.
And you pointed out the American Heart Association receives huge funding from food and pharma.
Yes, around $192 million annually last I checked. While they do important work, such significant funding from industries whose products directly impact cardiovascular health inevitably raises legitimate questions about potential conflicts of interest influencing their guidelines and public messages.
So let's be really clear. You are not telling everyone currently on a statin to just stop taking it tomorrow.
Absolutely not. That would be irresponsible. My position is about promoting truly informed consent.
Meaning,
Meaning, patients and doctors need to have honest conversations based on a clear understanding of the absolute benefits for that individual, the potential harms and side effects, and the alternatives, particularly lifestyle changes. Decisions need to be shared and personalized.
and you're particularly critical of how side effect data from statin trials is often presented.
Extremely critical, especially the common practice of using pre-randomization run-in periods.
Explain the run-in period.
Before the main trial, comparing the statin to a placebo even starts, potential participants are often all given the statin for a few weeks. Anyone who experiences side effects during this phase and drops out, they are simply excluded from the actual randomized trial.
So the trial only includes people who already tolerated the drug initially.
Precisely. This systematically filters out the early quitters due to side effects. When the trial results are then published, the rate of side effects appears misleadingly low compared to what happens in the real world where everyone starts the drug. I consider this practice a form of scientific manipulation, bordering on fraud, as it misrepresents tolerability.
And there's a lack of independent checking of the raw data for side effects.
Yes. We generally rely on the drug company's own analyses of their trial data regarding side effects. There's rarely, if ever, independent third-party evaluation of the raw patient-level data specifically focused on adverse events. That lack of independent scrutiny is a major gap.
You also raise the issue of regulatory capture, the funding of bodies like the FDA and the MHRA in the UK,
Yes, a very significant percentage of the budget for these regulatory agencies now comes directly from fees paid by the pharmaceutical industry they are supposed to be regulating.
which creates an inherent concept of interest.
It certainly creates the potential for conflict of interest. Can an agency be truly objective and rigorous in evaluating a company's products when that company is effectively a major financial contributor to the agency's operations? It's a serious concern.
So, pulling it together, why do major bodies like the American College of Cardiology, the American Heart Association, still broadly recommend statins for primary prevention for so many people?
I believe it's a complex mix. Flawed interpretation of the underlying science, perhaps focusing too much on relative risk and surrogate markers like LDL, a deeply entrenched dogma passed down through training, the undeniable, pervasive financial influences we've discussed.
And maybe fear.
And perhaps, yes, a reluctance among some individuals within these organizations to speak out forcefully against the established view, given the potential professional repercussions and the power of the opposing interests.
You reference Robert Kennedy Jr.'s initiative, Make America Healthy Again.
Yes, and the point there is that to achieve genuine improvements in public health, whether in the U.S. or elsewhere, we arguably must address and remove these commercial distortions of scientific evidence and health information.
It's fundamental.
Feels fundamental to making real progress. We need unbiased information to make sound policy and personal health choices.
You also connect this to a World Health Organization report on commercial determinants.
Indeed. The WHO is increasingly recognizing and reporting on the profound and often negative impact that commercial entities and their practices have on global health outcomes. It's becoming a mainstream public health concern.
Let's reiterate your overall position. You're not anti-science, not anti-drug.
Absolutely not. I am pro-science, pro-ethical medicine. I am not anti-drug or anti-pharma in principle. My stance is purely about advocating for ethical, transparent, and truly evidence-based medical practice centered on patient well-being.
Drugs have a role, but maybe not the primary role they often take.
Precisely. Medications certainly have an important role in treating many conditions. But for many chronic diseases, including heart disease, I firmly believe that diet and lifestyle interventions are often more effective at addressing the root causes.
And usually with fewer side effects.
Significantly fewer adverse effects, yes. I often describe food, particularly whole, unprocessed food, as precise medicine. It targets multiple pathways simultaneously in a beneficial way.
And there's a quality of life aspect, too.
Yes, that's a huge point. Lifestyle changes, eating better, moving more, managing stress, almost invariably improve people's overall quality of life, their energy, their mood. Many long-term medications for chronic diseases, while potentially extending life slightly, can sometimes detract from quality of life due to side effects.
Now, you briefly touched on specific groups like lean mass hyperresponders. Who are they?
Yes. These are typically very fit, healthy individuals, often on low-carb diets whose LDL cholesterol shoots up dramatically, sometimes to very high levels, while other markers like triglycerides and inflammation remain very low. Their specific risk profile is still being studied and debated.
So it's not always straightforward. And you mentioned Dr. Ron Krause's work on saturated fat.
Yes, Dr. Krause has done important research showing that individuals respond differently to saturated fat intake. For some, it raises the large, fluffy LDL particles, which may be less harmful, while for others, it might raise the small, dense particles, potentially more concerning. It highlights the need for personalized approaches.
Okay, back to familial hyperlipidemia,
Yeah.
FH. You stressed lifestyle, but what about medication? Is there a role for statins there?
As I said, lifestyle is paramount even in FH to address underlying metabolic issues like insulin resistance, which many FH patients have. Assessing LPA is also crucial. For some very high-risk FH individuals, particularly those with proven coronary disease or very high LPA, a low-dose statin might be considered as perhaps a halfway house.
But only alongside aggressive lifestyle changes.
Absolutely. The foundation must be optimizing lifestyle. The statin, if used, should be supplementary, not the primary focus, and the decision made with full informed consent about the limited absolute benefits even in this group.
You explored many of these themes in your documentary, First Do No Farm.
Yes, the film delves into the issues around statins, overtreatment, commercial influence, and importantly, the potential for preventing and even reversing heart disease through comprehensive lifestyle changes. It's available at nofarmfilm.com.
And you also highlighted the work of Dr. Bimal Chaudhary in India.
Yes, Dr. Chaudhary has had remarkable success over decades running lifestyle programs in India, demonstrating reversal of coronary artery disease using diet, exercise, stress management, including Raj Yoga meditation.
Meditation had an independent effect.
His work suggested it did, yes, highlighting the profound importance of stress reduction and perhaps even spiritual transformation in tackling heart disease. It's a truly holistic approach.
So the core message seems to be statins might have a limited role for certain specific high-risk individuals.
Potentially, yes, when used judiciously and with full transparency.
But for the vast majority, especially in primary prevention, the focus needs to shift dramatically towards informed decision-making based on absolute benefits, individual risks, and prioritizing powerful lifestyle interventions.
That's precisely it. It's about empowering patients and doctors with accurate, unbiased information so they can make choices that truly align with the evidence and the patient's own values and health goals.
Okay, let's try and summarize this deep dive. Clearly, the controversy around statins is complex, it's multifaceted,
Definitely not black and white.
and just focusing solely on LDL cholesterol is the main target.
Yeah.
Well, it seems like that probably oversimplifies a much more intricate picture of cardiovascular health.
Yes, inflammation, metabolic health, insulin resistance. These seem increasingly central.
We've also seen how commercial interests can exert a really significant influence on the information we all receive, patients and doctors alike.
That's a thread running through this entire discussion, the impact of commercial determinants on health knowledge and practice.
And perhaps most importantly, the huge potential of comprehensive lifestyle changes, diet, exercise, stress, for both preventing and maybe even reversing heart disease seems massively underrecognized and underutilized.
It really does deserve far greater emphasis in clinical practice and public health policy.
So, critical thinking, a willingness to question that conventional wisdom, it seems absolutely essential when you're navigating all this conflicting health information.
Absolutely. We need to look beyond just the headlines, beyond the relative risk numbers, and really dig into the nuances of the evidence, the absolute benefits, the potential harms.
We really hope you, the listener, We'll explore the resources we mentioned, Dr. Malhotra's book, the documentary First Do No Farm, the BMJ articles, to get an even deeper understanding of this really critical topic.
And maybe take some time to reflect. Think about your own experiences or conversations you've had with doctors about cholesterol or statins. Consider the absolute risks and benefits in your own unique situation.
And we'll leave you with this final thought to mull over. Given everything we've discussed today, what fundamental shifts might actually be needed in how we approach preventing and treating heart disease?
Yeah, what's the right balance? How much emphasis should be on individual empowerment through lifestyle versus relying on pharmaceutical interventions?
It's certainly food for thought.